So at this point, I'm going to introduce my good friend, Rhonda Mitias. I met Rhonda at the very beginning of my journey in autism. She did an evaluation, I guess it was the Dibbles, on my son when he was 3. So we've known each other for a long, long time. And I think now we're friends and we enjoy each other's company. And she's a great person, and she has so many degrees that I would not even try to tell you all of them. But today she's here to talk about feeding therapy. So I'm going to throw it over to Rhonda and take it away.
Okay, great. Can everybody hear me?
Mm-hmm.
Yes.
Yep.
Yes.
Okay, well, I thought I'd start off with how to know whether your child has a feeding disorder or needs feeding therapy. If your child, their selectivity, if you've heard that, food selective, picky eater, but if your child accepts 6 or fewer foods on a regular basis, that's a big red flag that you need a little bit of feeding therapy. If they're eating foods from less than all 4 of the food groups, a lot of kids will eat a protein, maybe chicken tenders, breads, but no vegetables and no fruits. If they're not eating food from all of the food groups, then we need to take a look at that. Textures, accepting less than 4 different textures, and the textures are thin liquids, pureed, which is like a pudding, dissolvable crunchy things like goldfish crackers, and chewy foods, which are most of your proteins. If they're accepting less than 3 levels of textures, or if their textures, the level of their textures that they will accept is not age appropriate, they should be taking all 4 of them. If they're not taking all 4 of those different textures, then we need to look at that. With the behaviors,
again, we say what the textures are again.
Okay, well, you've got your thin liquids, which are your drinks, and soups. Soups are considered thin liquids. Pureed, which is a pudding type texture. Dissolvable crunchies, which are like goldfish crackers, and then chewy foods, which are mostly your proteins and things like that. Almost all of our kids will eat crunchy, chewy, crunchy, dissolvable crunchy type foods, chips, that type of thing. French fries, I would even consider chewy or crunchy, depending on how long they've been cooked. If your child is refusing all non-preferred foods, they won't even try a new food, and you can't even get them to try something new, then you probably need a little bit of feeding therapy. Not always do we need 6 months to a year of feeding therapy. Some of the difficulties that they have can be fixed in a matter of a month. The behaviors that you see with your feeding disorders are what we would call refusal behaviors, or CIs, combined inappropriate mealtime behaviors. These are blocking behaviors. When you've got a child that's batting at the spoon, turning his head, tucking his chin down, clenching his lips, that type of thing, covering their mouth with their hand, refusing to accept a bite. Those are refusal behaviors. Then there are escape behaviors, which are a little bit more aggressive, when they're biting, pinching, kicking, throwing foods, spitting food, and I would include gagging and vomiting in these. Sometimes gagging and vomiting is related to texture aversives, but not all the time. Sometimes it's just a behavior to escape. If you've had previous treatment for feeding therapy and it's failed, then that would make you a prime candidate for feeding therapy here. Medical concerns from your doctor. If they look at your child's growth curve and it's not where it should be. A lot of times our pediatricians get really, really busy though, so that's something that parents need to watch. You can download a growth curve on your phone, the pediatric growth curve. If you know what your child's height and weight is, you can look at exactly where they are on that growth curve. If they're not where they should be, then you want to seek some help. Now, sometimes feeding not accepting a new food may be related to some difficulty that they're having oral motor. Their tongue musculature is not appropriate, not age appropriate. They've got a weakness on one side of their tongue. It's not really something that us as parents, we don't always look in our kids' mouth. We don't know that they're having trouble moving the food back and forth and that type of thing. But sometimes you can look in there and it is obvious that there's some difficulty, and that's a part of what I treat. What we do here in terms of the evaluation, the steps in coming in would be a referral from your pediatrician. You complete some pre-evaluation paperwork, like a case history. We would collect your medical records from your doctor. I asked my parents now. I didn't ask when Missy came to see me, when some of my other parents that have seen me were here. But now I ask my parents to record on their phone at least 3 meals, a breakfast meal, a lunch meal, and a dinner meal, so that I can get an idea of what their behaviors are. Some kids will get up and just leave the table. They don't sit at the table to eat with their family. Your child is not eating the same meal that your family is eating each night, and you're preparing 3 and 4 different meals for everybody. That is something that you really need to come in and have looked at. Parents should never have to make more than 1 meal. Your child should be eating the exact same things that you are eating. So when we come in, that's one of the reasons that I like to have the video. I like to see what the parents are eating versus what the children are eating. That gives me a really good insight into what's going on in the home. During the evaluation, I do an observation of your child eating a preferred food, and then I present non-preferred foods. And sometimes I'll do a texture assessment to see what textures they will eat and what textures they won't. If a parent can't really tell me, well, I really don't know if they'll eat this type of food. Once we get finished with the evaluation, then I'm able to determine whether it's a mild or a moderate feeding disorder based on the different categories that I have that they have failed to meet standards in. And then when they come in for therapy, it's very regimented. It's very step by step. The data lets me know exactly when to go to the next step. There are 2 different types of therapy. Has anybody ever gone and had any type of therapy done for their child for feeding?
No. Susan, whose hand is up right there, she joined us late, so
Okay.
She has done some feeding therapy.
Okay, well, there are 2 different types of feeding therapy, 2 different approaches. One is an SOS approach. It's called sequential oral sensory approach. That's where mostly done by an OT, but occasionally done by a speech pathologist. They go in, they touch the food, they look at the food, they smell the food, they touch the food, they touch the food to their mouth, they taste the food, they lick it, they kiss it, they do all kinds of sensory things with the food. But percentage-wise, very rarely does that move on to a child successfully eating and expanding their diet. What we do here is it's a behavioral approach. It's rooted in the principles of ABA, and we start off with presenting a reasonable demand, both with the texture and with the bite size. Once we present the reasonable demand, we go through certain steps. We want them first to accept the bite, then we want them to accept the bite and keep it in their mouth. Then we want them to accept the bite within 5 seconds and swallow it within 30 seconds. Then the next step is reducing the behaviors, those bad behaviors that are surrounding the acceptance of the bite. Once we are able to decrease those behaviors down to an acceptable level, then we can start to increase the bite size and then the texture up to a normal texture. And that's basically what I do. It's all data driven. Some of them have taken as long as 6 months. I don't know how long Misty's took. Do you remember? No?
It's about 6 months.
In about 6 months? How about you, Becky?
It was rough.
It was rough. How about you, Becky? How long did Noah's take?
It took about it took about, I'd say about 7 or 8 months. It took a little bit longer.
And Noah has trouble self-feeding. The last
Yes, well,
step, we worked.
Well,
on
he has
for a
motor
long time.
processing problems, so I think that has a lot to do with it. But he's actually doing pretty good with his utensils now. But and there still is a lot of fighting at times. But what I've discovered is that my 9-year-old typical child, I argue with her verbally about what she's going to eat, and I argue with Noah physically. So I think I'm getting the same response out of both kids. So I kind of feel like it's pretty typical. He just can't talk. So.
Right. I see a wide variety of kids in terms of the difficulties that they have. My worst patient was one that was drinking 16 Pediasures a day, and that was her primary dietary intake, other than just snacks and junk food. And when she left, she was eating 21 to 24 normal texture, healthy foods that she would feed herself. That's probably the worst case scenario that I've had. I did have one that was on a feeding tube, or that wasn't on a feeding tube, but was threatened with a feeding tube, and that's why they were there. And we were able to get him. But then after that, they still weren't happy with his growth curve, so they still gave him a feeding tube. But I love doing feeding therapy. I get a lot of reinforcement myself from it, because I see progress really fast. Does anybody have any questions?
I have a question.
Sure.
So my son hasn't tried feeding therapy yet, but based on what you said, or like the markers, he probably does need to be evaluated. So if you all are a secondary place, where would I take him to be evaluated?
No, I do the evaluations. What we do here is the steps for getting in for an evaluation are we get a referral from your pediatrician. Then you'll fill out paperwork. I usually have my parents, like I said, do the video of the 3 meals. And one of the things I've just started doing really with this last group of patients that I do evals on is I've had them make a menu. What we want to happen by the end is for you to have at least a 4-day food rotation, so that your child doesn't eat the same food again for at least 4 days. For example, if they have pancakes for breakfast, pizza for lunch, and chicken tenders for dinner, then they would not eat any of those 3 meals again for 4 days. They'd have something different each day for the next 3 days, and then that might pop back up on your menu. But I encourage parents to do a menu. We always at school, we do visual schedules for our kids, but nobody ever does a visual menu for them. They like to know what they're going to have for dinner. They like to know what they're going to have the next day for breakfast. And so having that as knowledge, knowing what's coming, has been really helpful for my son. I have a 16-year-old with autism, and it's one of the reasons that I got into this, is because he had limited his diet to almost nothing. The other thing that I do look at, and I do believe in, you'll have a lot of people that, just blow people off about this, is I do believe that there are food sensitivities. And as a prerequisite, I do have to have a medical clearance from either your pediatrician or gastroenterologist saying that your child is physically, there's no medical reason why they can't do behavioral feeding therapy. And I like for my parents to have food sensitivity testing done. That's not always possible. But a lot of times our kids will limit what they're eating for several reasons. Either one, it's what they're offered and what's available. we as parents, we get busy. I'm guilty myself. I get busy. It's easy to pop a pizza in the oven, and it's easy to throw some chicken tenders in the microwave. And if they have that too often, that becomes a routine, just like anything else. And so then they don't want to vary from that routine. So that's one of the reasons we want that calendar and that menu, so that they know what's coming. Looking at that calendar and that menu becomes the routine.
So Rhonda, I want to draw your attention to the chat box. Nicole is asking a question that I think is really good. Do you see it down there? She says, are you able to evaluate and treat a older, high-functioning child with many food sensitivities and allergies? This makes it harder to feed my child, but there are other things he could eat that he won't regularly eat or doesn't like the texture of.
Right.
So, GFCS, kids that are gluten-free, casein-free.
I think the oldest patient that I have treated is, up to now, has been my child, who is 16. And it's really hard to treat your own child. But we've been able to get him to eat salads. We've been able to get him to eat all kinds of green vegetables, the ones that he's not sensitive to. He's sensitive to a lot of things. He's sensitive to broccoli. He's sensitive to, but he can eat Brussels sprouts, asparagus, and salads. So yes, I can treat older children. I do approach that a little bit differently. I give them more options and give them a little bit more control than I do the little ones. The little ones, I'll be honest, the little ones, and Missy and Rebecca can tell you, the first 2 weeks are really rough. I mean, it's a screaming fit. It's a yelling, screaming. Rebecca will tell you it sounds like torture.
Yeah. Well, I know it was actually a little bit longer. It took, because there's not a lot that you can reward him with that he'll fall for. So, I mean, it took a lot to actually, but once he started and he realized that wow, if I just do this, I get this. I mean, it was awesome. And all we really had to do is sing to him.
Yeah, he loved those songs.
Yes.
You're the reason I made the book. I made a book of children's songs because I was running out of songs to sing to Noah. But of course, like I said, I give them 30 seconds to swallow that bite once they accept it. And most of your childhood songs are 30 seconds. So that's the best reinforcement to use during that time when they accept the bites.
Well, and we've been done with feeding therapy for a long time. And to this day, if I mute the television, if I stop making any noises and I get really still, he knows, oh no, I better eat this. I mean, he knows. He'll stop what he's doing and go, oh, okay, I should be eating.
Yeah. And a lot of times when he's here and I'm feeding him here, just because he hadn't eaten yet, if he doesn't want to take the bite, I can say, take your bite. And he's like, oh, it's like back in therapy.
Yeah.
Bite. Yeah.
So how about like for example, my son will not do the purees. Like if it were pudding or like ice cream, like anything like that, he calls it slime, and he doesn't want to have anything to do with that. So is there words of encouragement? Like, I usually just don't argue with him about it. Sometimes I'm like, oh, come on, you can just try it. It's not going to kill you.
Well, there are not a whole lot of foods that you or I or any of us eat on a regular basis that are puree. Mashed potatoes. Mashed potatoes are kind of pureed. Grits, applesauce, yogurt, and pudding. Those are kind of the things. Can y'all think of anything else that you eat on a regular basis? But
no. Food.
When I say purees, I mean, that's where I start with most of the kids. I don't necessarily think that we all have to eat purees of that texture, because you can always, like yogurt, it's a great source of calcium, but you can use other sources of calcium so that you don't have to eat yogurt. The nutritional part is the thing that I'm the most concerned about. Most kids will eat pureed fruits like applesauce, or even if you oranges, you bite into an orange and it becomes a liquid. Most kids will eat that type of thing. So I think when you're talking about the texture being slimy, maybe that's just yogurt or just a particular food that you're trying to get him to eat. I don't necessarily think it's that texture. But I would check that. I would do other foods as a puree. But when I'm talking about puree, that's sort of where I start my therapy. If they're not eating any vegetables, fruits, vegetables, and they're young, they're little kids, I go all the way back to purees because that gives them an opportunity to taste the food. It sticks to the spoon. It's easy for me to get it into the mouth, and it gives them an opportunity to taste it. Repeated exposure to the taste is what gets us the acceptance. And I can't say that enough. Let me say that again. Repeated exposure to foods, no matter whether it's the texture or the taste, is the key to increasing a child's dietary variety.
So let's thinking of that. Let's say that we want to add rice or something like that. And if our goal is to add rice, that means we're going to serve rice every 2 days, every 3 days for weeks and weeks until we get them to take it, right?
Mm-hmm.
And is it smarter to always serve the rice the same way or
Yes.
always serve it the same way?
Always serve it the same way. Sameness, they love sameness. Once you get an acceptance and you've given them that food and they're accepting it readily and they are self-feeding it, and then you can add something to it. You can add some spices, a little bit of spices to it. Initially, starting out, I've had children that and I think I did this with Misty's. I added butter and sugar to the rice, which makes it yummy. And my cornerstone of everything is I don't ask my kids to eat something that doesn't taste good. I mean, I don't ask them, I'm not asking them to eat hummus, which I didn't like initially. And I'm giving them a reasonable demand. I've seen parents do this in restaurants. I've watched it and laughed. They're at another table and they've got this big spoonful of something and they're at their kid's face, just try it, just try it, just try it. And they've got a heaping spoonful of it. We don't do that. The first time I tried hummus, I didn't take a spoon and scoop a big spoonful of it and stick it in my mouth. I start with the size of a bolus, the size of a grain of rice. When I say a reasonable demand, that's a reasonable demand. And hummus is a puree, and a good one. It's a lot of protein.
I have a question. So we do a lot of feeding therapy. I have a son who has severe oral motor difficulties, but my other son, we just discovered when he had tonsils out that he has a laryngeal cleft. So he's got a little hole between his airway and his esophagus. So he's at high risk for aspiration.
Mm-hmm.
And so he has a swallow study tomorrow morning, but we're pretty sure that he still can't drink thin liquids, which we've known since he was like an infant. But we can't get him to drink thin liquids. We can't get him to drink thick liquids. He's really resistant to drinking like his thickened apple juice or almost anything thick. Even if it's like a smoothie, he'll be like, you put thickener in this, I'm not drinking it.
It changes it doesn't really change the taste, but it can get kind of gooey depending on what type of thickener you're using. Now the thickeners are not all equal. Some of them get gooey, and we've had to try them as speech therapists when we were going through school, and some of them do change the taste. As far as I'm concerned, they do change the taste. But the longer you leave it in there, on some of the thickeners, the thicker it gets. So you have to be careful with those. And there are some that will stay consistent. Have you tried a different thickener? Have you tried all the different ones?
No, we haven't, because we had some GI difficulties we were working with too, so that kind of limited our options. Both my kids have a history of neck, so for a long time that meant they couldn't drink like a bunch of thickeners. So we've tried, I think, 3 thickeners, but not. But basically, in general, I mean, it's mostly behavioral. Like, it's absolutely behavioral, where he's just like, no, I'm not doing that. And then he didn't like drink anything for 3.5 days. And his poop and his pee, you can totally tell that he's not drinking enough when he was taking thickened liquids. So we're just trying to figure out, like, all right, he's gone through feeding therapy and can do thin liquids if he does them carefully and correctly, you know, like if he sits down and he takes small sips and he, you know, tucks his chin and he has a small straw and things like that. But he's 4, and getting him to do those things like all at once is
Not always easy.
a pretty tough ask. Yeah. Almost as difficult as getting him to drink the thick liquids in the first place.
Will he eat ice?
He might. I don't think we've let him.
I have, sometimes you can ice, but you want to make sure that his teeth are, that you have done mouth care, oral care,
Mm-hmm.
so that everything is clean in there, because if he does aspirate, you don't want that to end up in an infection. But if you can get him to eat ice chips, if you think he can, once you get his swallow study back, if it's, they say it's okay for him to drink thin liquids, I would try ice first. And you can, not the McDonald's type ice, but you can, I'm trying to think of who has it, maybe Sonic.
Sonic has great ice, yeah.
The one that we call snowman poop.
Mm-hmm.
And that's the way we got one of ours to eat ice. We made it a joke that it was snowman poop, that type of ice. But I would try the ice first, but make sure you've done very good oral care so that there's not a lot of bacteria in the mouth, because if he aspirates the water, then the bacteria is going to go with it.
Mm-hmm.
But I would also, if you can't have the thin liquids, then I would check some of the other thickeners.
And so what about different, like, did you ever do like a contest with him? Like thicken many different types of juices to see like a taste test of which juice is the best thickened? Does he prefer one thing over another?
He definitely his favorite is lemonade. If he's going to be drinking anything thickened, but we haven't done that. And yeah, he's got a pretty limited repertoire of like drinks in the first place. So
I know that this is a crazy thing to like say to you because of how exhausted you are with twins, and one of them has such a huge disability. But the more of like a show you can make it, probably the more he'll do it. So just the thought of having to put three different cups up, I know is exhausting, but I bet that would fix his little caboose, because I bet if it was, something more like a game or something, you might be able to get him. But I know that's hard because you're tired.
Yeah, it's just yeah, it's tough too. My least favorite thing about thickener by far is that it's really hard to obtain. A lot of talking to people on the phone about getting thickener in the mail. But we can definitely give that a shot. And we'll see what the swallow study says tomorrow.
Yeah, that's your first order of business, is find out what that swallow study says.
Yeah.
Does he have difficulty with eating anything else?
No, he has no difficulty eating it. It's just thin liquids. Like even slightly thick liquids, like he's much less likely to choke on milk than he is on water. So just just like
water.
It's just a tiny little bit, but it seems to make a difference for him. But I mean, like, we have so many battles over from a water fountain. Like, no, and so many fights in restaurants, like, no, you cannot have water. You have to drink your chocolate milk. Which, these are fights no one else is having. Yeah, sort of, that's our thing that we're with him, that's what we're struggling with. With his brother, he's in therapy to learn the oral motor skills necessary to eat. So.
Any other questions? Misty, you haven't asked any questions.
You said I didn't need to be in here. I'm just
I
listening.
think I'm just going to go to Misty's preschool class one day a week and teach therapy.
Cool. It's lots of fun. I do have a student that only eats goldfish, and so she would eat her mom's cookies. If her mom did the cookie, mom brought macaroni and cheese, and so I tried that. She wouldn't try it, and so she'd only eat goldfish. So and they kind of, parents look to teachers a lot of times. Can you introduce them? And I think in my preschool classroom, I can do a little more of those things and try, and I'm good. I'm good with behaviors of, no, we're going to try it. But it's difficult. But I like what you said about the OT thing, because when Sam was little, we tried, the OT made a suggestion of where we had a picnic and we introduced him to new foods away from the table and did a picnic, and oh, that was a hot mess. That did not go up. It didn't work.
Well, you want your mealtime to look like a mealtime with the family sitting down at the table. And that's the goal. That's the end goal for feeding therapy, is for everything to look like a meal and for everybody to eat the same thing.
Introducing new foods away from the table did not work. Not for Sam. So.
I've not found a child that will play with the food and eventually end up eating it,
Right.
licking it, kissing it. I've not found one yet. Marcus Autism Center, where I trained, actually did a study comparing the two. They sent one of their therapists to become certified as an SOS therapist, and they tried introducing new foods using the SOS approach. It never took. And then they did she's also a behavioral therapist, so she did the behavioral, and the child was eating within 3 weeks. So I have not found, and I've compared both approaches. I had the option of doing certification in SOS. I chose behavioral. I just know with ABA, it works with all kids. Typical developmental delays, kids with autism, it works. I can't hear you, Becky. You're muted.
There you go. Gotcha there, Becky.
Okay, thank you. I said I've been able to apply some of the principles to my older daughter, who's typical, and they work with her as well. So, very helpful.
So for
how close? Sorry.
Oh, go ahead, Susan.
How close should the meals of the whole family be? I know my husband and I eat a lot of stuff that's a tough sell for a 4-year-old. We definitely do a lot of different meal preps at every meal. And it would be great to do fewer, but at the same time too, to what extent should we expect a 4-year-old to eat grown-up food?
Well, 4-year-olds should be able to eat exactly what grown-ups are eating, just in smaller bites and smaller sizes or lesser textures. Like my kids, my older neurotypical children were eating sushi and things at that age. I mean, they will eat anything, but we introduced them to it, and they didn't have autism. They weren't Zach. When Zach was little, the very first time my husband, this is a true story. He said, "I've got this. I'm going to get him to eat a tomato. We're fixing to stop this. You having to make two different meals, one for us and one for him." And it was a small piece of tomato. He put it in his mouth and was going to make him eat it. And Zach threw everything up all over the table, and he said, "Okay, I'm done." Dad said, "I'm done." And that's what happens. But you have to start it off at a very young age, and you start off with a reasonable demand. And it's the exposure. It's all about the exposure to it. My kids eat Thai food. They eat Mediterranean food. We travel all over the world. They travel everywhere, and they eat foods from all different countries.
Now, does Zach eat those meals as well?
Zach is starting to eat those meals as well now that we've been doing feeding therapy. But we have to be careful with him because he has a food sensitivity to gluten and soy.
Okay.
And he has certain reactions. Zach actually breaks out in a terrible rash and gets scabs, and they call it eczema. It's really not eczema. It's an eruption on the skin due to an allergy.
I just feel like the hot foods, like in my house, my husband likes to eat really hot food, and it's taken a while. Like for our typical son, Jake, he's now gotten to the point where he can eat the hot food. I don't really like it either. Sometimes I'll eat it. So I would not usually think that I would ask you.
Well, now that's not a completely different meal, but you can scoop a little bit out before you put those spices in there for your children. I've done that before.
Why don't you tell my husband that?
That's not something that I consider making a completely separate meal. I had gotten into the trap of making something for the family, and then I would make something completely different for Zach, whether it was a pizza or chicken tenders or pancakes, those were our cornerstones, frozen pancakes. And at one point, it was honey buns every meal when he was little.
Whoa.
It was extremely bad. And I realized that it was gluten when I saw the results. And this is something that's really disgusting, but I always tell my parents, the other thing I have some of them do is download an app on their phone so that they can document what their child's poop looks like. Because for everything that we talk about that's going in, we also need to talk about what's coming out. Kids, if they're, especially some of ours that take medication that will cause constipation. If a child is constipated, they don't want to eat. They're bloated. Nothing's coming out, so they don't want to put anything else in. You have to make sure the whole system is working and everything is running correctly. It's a bodily system, the whole system.
Miralax. Lots of Miralax has been used in our house.
Same here.
Yes, I know, Elizabeth, I know.
But what the trap that we got into initially was it just became normal. And we forget what normal is.
Right. Yes.
Forget that it's not normal to make 2 and 3 different meals. If you have 2 kids on the spectrum and one that's typical, the parents and the typical child eat the same thing, then you make 2 separate meals for the other 2. Yeah. That's not normal. We forget what's normal.
Yeah.
Well, and I'll tell you, I had somebody tell me once with Noah that, and this was a professional, they told me that with Noah, that if he got hungry enough, he would eat anything. And that is not true with kids who are food resistant. It is not true. They will starve themselves to death. Noah was down. He had stopped eating all meats. He was eating yogurt raisins. I was trying to get him to eat protein bars because he wouldn't eat anything else. So we were at yogurt raisins, and for some reason the kids always loved tomatoes. So he would eat baby tomatoes or cherry tomatoes. He would eat raisins and milk. And as you can imagine, this meant everything ran right through him because he got nothing solid. And he had circles under his eyes. It was awful. And he wouldn't touch anything else. He would throw it at you. He would spit it out. And when we first started with Rhonda, it took about 5 weeks to get him to do anything. But once he started feeling better. He started looking better. And you could see it. I mean, it was almost an instant results. And to this day, it is the most productive therapy he has had. And we are so glad that we did it. I mean, and I'll tell you, there are days I left almost in tears thinking this kid's never going to eat. But it was completely worth it.
Some of my kids, though, will plump up once they start eating really well. Noah has never gained weight.
No.
Noah gets taller. He's never gained any weight.
He weighs exactly 50 pounds for the past 3 years, but he has gotten about 7 inches taller. But he doesn't look ill anymore. He doesn't have circles under his eyes.
Those dark circles are gone. I do remember those, the dark circles under his eyes.
I keep a picture of it so I can remind myself when I don't want to make him eat what he looked like.
That's good. I have a couple pictures like that on my phone that I will never, delete or move off. Like if I move off older pictures to like a storage, I always leave those on to help me remember what it used to be. So.
Exactly. I have a few of those.
We should all keep those.
Yeah.
Most of mine are proof.
Yeah.
Evidence.
I want to remember, I don't ever want to go back to that place. I remember what that was. That was bad.
Don't repeat this. Yeah.
So Rhonda, what can you tell about their eyes? Like if they're malnourished, or what do their eyes show?
Well, Noah's eyes he just had these extremely deep, dark circles under his eyes. Now, some people have that, and it's genetic. I have it, and mine is genetic. Although I do know that when I'm getting the right nutrition, mine are better, but they're still there. When I'm eating terrible, which I do too, I tend to do, I'll get my dark circles will come back.
Well, and with Noah, not only was you could visibly see it, he was miserable. He was crankier. He was not a happy person. And honestly, he was hungry. Once he started getting the right foods, I mean, he became this beautiful, happy child. I mean, because he was just honestly hungry. And he didn't know that was the problem. You can't tell an autistic kid, oh, if you just do this, you'll feel better. They don't hear it, or mine doesn't.
The biggest difficulty that I've had as a clinician in doing feeding therapy is getting food sensitivity testing completed.
Yeah.
For my patients. Most people have to go to Nashville, up near Franklin, Tennessee. We went to Franklin to see Dr. Kolb. There's a physician over in Little Rock. There's not very many places. I'm trying to locate a place here in town that can do food sensitivity testing for us. My ex-husband owns Ageless Men's Health. He did my food sensitivity testing and our families. I'm looking at RedMed right now to see, because his office was not certified for pediatrics. They couldn't do any pediatric blood work. But most of our RedMeds, our minor med clinics, can do pediatric blood work. If I can get one of those clinics to agree to send off that blood work to the lab that we used, loved so much, that was so good, I would love to be able to refer my patients there for food sensitivity testing. How many of y'all have had food sensitivity testing?
What is it? I don't even know. What is it?
They take your child's blood and they can determine which foods that they have trouble digesting and the proteins for. Like gluten. You know, we'll have gluten allergies, but then there are some kids that it doesn't show up on a normal allergy test, but it will show up in a blood test.
Now, don't have that Everly way. I mean,
Yeah,
that you can do
Everly will.
yourself.
I have, and that's funny that you said that. I have those. I have one. And what my goal is to do, and I haven't done it yet, is to do this test on myself and Zach. I have 2 of them.
See how accurate it is.
The results from this test to our results from the lab test to see if these are comparable. If they are, then you can just order these online and do them. And it's a finger
Put it
prick.
close to the screen. Put it up close to the screen.
And there are 2 different levels of testing. This one tests 96 foods.
Where'd you get that?
I think I ordered it online. And you register it with, you register it and then do the test and send it in. It's sort of similar to the colon screening that you can do now yourself, and the genetic testing that you can do. The 23.
That's not a blood draw, right? It's just a swab?
No, it's a finger prick. You have the little thing that you prick the finger and then put the blood on it.
Goodness.
And that the biggest challenge we had at the doctor's office getting Zach tested was getting his blood. And we did do it with a completely empty doctor's office, other than the staff, because there was a lot of cussing going on. Not me. Him.
Oh, remind me to tell you later what Zach told me today about the gas station.
Okay. I can't imagine. I didn't get an answer. Has anybody done food sensitivity testing?
No, I haven't.
Elizabeth, you've not done food sensitivity?
Mm-mm.
Had you heard about it?
Mm-mm.
No. Most parents with kids on the spectrum have heard about food sensitivities. And I learned fairly early that Zach was sensitive to gluten. He was diagnosed at between 3 and 4, and he'd never had a formed stool. He'd been a breastfed baby, and that's the way his stool had always looked, that yellow grainy stool. And I came home after getting him diagnosed. I'd been reading a pamphlet in the waiting room, and I told my husband, I said, he's gluten intolerant, and it's part of what is causing his autistic symptoms, and I'm going to put him on a gluten-free diet. And as a physician, he said to me, knock yourself out. It's not going to help. It's not going to change anything. I changed his diet completely on a Thursday, and by Sunday, he had his first hard brown stool. And he started talking right after that. And we started seeing huge progress right after that. But Zach had always had eczema to the point that he was broken out in all of the crevices of his body, and he was always itching, and that went away. His runny nose went away. So what the kids are putting in their bodies does have an impact on not only how they feel, but their behavior as well.
Well, I think it's been really enlightening to talk about this and to think about it. It's a hard subject, to face and to think about. So,
guys, I'm not a public speaker. This is really one of the very few times that I've ever made a public speech. So y'all please call Rebecca and let her know how I did, if there's anything that I can do to improve, because I'd like to do this again. I'd like to educate parents better on food allergies, food sensitivities, and feeding disorders. But I know I use my hands a lot, so I know that's going to be one check mark on your box.
oh, you're so silly. That's not true at all.
But I really need help in doing better at being a public speaker.
We're not grading you, Rhonda. We all think you did a
I
fine
want them to grade me. I want them to call you and tell you.
All right. Well,
Besides feeding therapy, I also do a full range of speech and language. And I am you were talking about my degrees. I am a teacher, K through 6, an audiologist, a BCBA, and a speech language pathologist.
That's great.
she just needs to spend some more time at school.
Yeah. I'm finished, I think.
Okay. All right, everybody. Well, it's really nice to see everyone. And next week we're back with, I think it's Peg Pickering next week. And Peg is going to talk about holistic approaches to treating disability. So it's good to see everyone. Have a great week. And thank you, Rhonda. And we'll see everybody next week.
Bye.
Bye.
Bye.